It's a great pleasure to see several excellent projects presented today by our ICU fellows and residents. Very exciting progress. We're gonna hear their excellent work. It's also very exciting to see increasing attendance to these meetings, which reflect more research interest, and I'm very pleased about it. Just want to put things in perspective for the presentation today. We have started with our fellows and residents a research program in late 2019. And we used this is in our hospital, we use an ICU database that has data for almost 17 years. And also we have a data for severe acute respiratory infection that we are also allowing the projects to be used for residents and fellows. So far, very exciting. We have 20 projects ongoing. 10 of them have received IRB approval, 8 been analyzed, and there are 8 with manuscripts written at different stages. The objective of this program for our residents and fellows is to get the experience of making a hypothesis, a research question, getting a proposal, submitting proposal, getting working with data, analyzing data, understanding the important statistics of the data, and writing paper. And we're very pleased with the great work that has been done by our fellows and residents that we're going to hear. These are the projects that are in progress. Some of them are different stages. Green means the step has been passed, so you could see some of them are in advanced stage, and some need in work because we have residents different years. So just reflecting different stages of the projects. So today we're going to hear 4 of these projects, and just want to make clarification that these projects are all work in progress. So some of them may not be very complete, so ideas and suggestions for the residents and fellows are welcome. But some of this work just really hot out of the press, just recent analysis. So some of it still needs some fine tuning, but I think we have a great material to present. The other thing that we just want to alert you that these topics are different, addressing different questions. And as a result, some of the studies are large, some of them small. It's really not the idea of, the idea here is to get through the experience of doing research project. But again, all the projects are exciting, and I hope that you'll enjoy and interact with our residents and fellows. We'll start with Dr. Abdurrahman Al-Mai. He's our ICU fellow. He's going to present about very interesting topic, which is no-code practices in the ICU and timing of no-code practice in the ICU. You're going to present the data that's been around 17 years, how we are doing with no-code policy. So Abdurrahman, please go ahead. You can share your slide. You're muted, Abdurrahman. Abdurrahman, you are muted.
Yes, now?
No, it's okay.
Just I will share. دكتور ياسين، بس تعطيني خاصية إني أقدر أسوي شير السكرين.
Rose, please, can you give Dr. Abdurrahman? Yeah, okay, you're good.
طيب بسم الله الرحمن الرحيم.
You can share this slide now.
Yes.
Okay. Abdurrahman, Can you make it full screen, Abdurrahman, because we can see your desktop?
Yeah, now full screen.
It's not full screen yet. It's not a view.
Okay, just wait. Now I think it's a full screen, yeah?
No.
Now?
Why don't you unshare and share again?
Okay, just.
Dr. Yasin, is Dr. Modi here already?
Should be, I expect.
Because I need to make them as co-host now. Because the name here is different from the name in the speaker and the flyer. That's why I cannot make them co-host immediately. Oh, okay. Siya yung best. Okay. I will make him the co-host. Okay. Is now the co-host. Dr. Hatem Arishi is here.
Should be here. Abdurrahman, are you able to share or not?
Yan. Hatem Hassan Harishi.
Why don't you put, Abdurrahman, if you are not, we'll start with another presentation, with the next one. Modi, you are here. Why don't you start with Dr. Modi?
Yes.
Yeah, okay. Can you share your slide? So Modi will present on hematologic malignancy patients who are admitted to the ICU after cardiac arrest, and then we'll come back to Abdurrahman.
Did the screen out؟ طلع عندكم سكرين دكتور؟
لا.
What about now?
Yes.
Okay, should I start?
Yes, please go ahead.
Good day, everyone. My name is Modi Yahya. I'm ICU resident in King Abdulaziz Medical City. My proposal topic is outcome in hematological malignancies patients admitted to the ICU after cardiac arrest in King Abdulaziz Medical City, Saudi Arabia. So hematological malignancies vary in incidence, etiology, prognosis, and survival rates, can result in significant morbidity and mortality, eventually leading to cardiac arrest with poor in-hospital outcome. As international, there is a study, retrospective study in multi-center in France, talking about outcome of cancer patients in general who had cardiac arrest, then admitted to the ICU, involving 133 patients, found that 18% were discharged alive from the hospital, with overall 6 months survival rate was 14%. As locally, in Saudi Arabia, the Saudi Cancer Registry documented on 2012 the incidence of general cancer was 14,336, with 52.6% were female. There is limited data regarding the outcome of patients with hematological malignancies and cardiac arrest admitted to the ICU. So our aim of the study is to report the outcome of hematological malignancies admitted to the ICU after cardiac arrest, specifically to measure ICU and hospital mortality and hospital length of stay, and to determine the predicted in-hospital mortality. The study design is a retrospective observational study of adult patients admitted to the ICU, conducted in King Abdulaziz Medical City from 1999 to 2017. Inclusion criteria: all patients above 18 years admitted in ICU with hematological malignancies, admitted after cardiac arrest. The exclusion will be patients with non-hematological malignancies and non-cardiac arrest patients. The sample size and technique: all patients in a prospectively collected ICU database maintained by data collector. It's including all demographic variables such as age, gender, in addition to physiological parameters like Apache, GCS, bilirubin, creatine, lactic acid, INR, and BF ratios. Statistically analysis, we compare of baseline characteristic and the outcome between survivor and non-survivor. Categorical data were presented as a frequency and a percentage and compared using the chi-square or Fisher-Exact test. Continuous data were presented as median with the first and third quartiles and compared using the Mann-Whitney test. So basically, our result is during the 18 years study, found that 36 patients met the criteria, 41% are survived with 48% who are died. The median age was 58 years. 75% were male gender. Found that diabetes mellitus was the prevalent chronic disease in 10 patients, followed by chronic cardiac disease in 8 patients and chronic respiratory disease in 3 patients. This table shows baseline characteristic of the patient with hematological malignancies who were admitted to ICU after cardiac arrest. 80% were mechanically ventilated, 75% required vasopressor, and had median Apache score with 29, with no statistical difference between 2 groups in terms of baseline characteristic, as you can see in this table, except for the level of lactic acid. Patients who had higher lactic acid had higher mortality rates. In this table, it's among 36 patients at 21 who died during the hospital stay. The median of ICU length of stay is 2.8 days. Hospital length of stay, the survived was found 51 days and died 19 days. Still the work in a process. More data will be collected about type of cardiac arrest and type of hematological malignancies. Multivariate logistic regression analysis will be carried out among patients with hematological malignancies admitted to ICU after cardiac arrest to identify predictor of in-hospital mortality, and adjusted variable will be chosen by statistically and clinical significance. Conclusion: the analysis selected difference in the Bentley variable, which was statistically and clinically not significant, except patients who had lactic acid found to be higher mortality rate. Thank you.
Excellent, Dr. Mahmoud. Thank you very much for this great work. Really very insightful and good presentation. So we'll open it for discussion and questions from the group. And we need help in unmuting the people who have raised their hands, which I don't know how to unmute them. Rose, can you unmute? Yeah. Dr. Ali Janoubi.
Assalamu alaikum. Thank you, Dr. Yassin and Dr. Amodi for this interesting presentation. A few questions. What is the definition of lactic acid, of high lactic acid in this study that you made it that you found out that if the patients exceeded this level, they will be having high mortality. Second thing, do you think that having the group of patients in King Abdulaziz Medical City, where we have they have strong rapid response team program to decrease the numbers of patients with hematological malignancy that are admitted with cardiac arrest? Thank you very much.
Okay, for the first question about the lactic acid, you can see the picture here in the DID group. The median was 6.5, the latest 4.5, and the average up to 12.1. And significantly is the p-value is less than 0.05. So it's statistically significant for high mortality.
So I think, Dr. Modi, what this table show, I agree with you. What this table show that between the patients who survived and the patient who died, there was difference in lactic acid. Lactic acid was higher in the patient who had baseline lactic acid, which was higher. So the one who died had higher lactic acid on arrival to ICU, 6.5, versus the ones who survived, 3.4. This is, I think, what the table shows. The ones who died had higher lactic acid at baseline. But we cannot say based on this data what's the cutoff after which patients are likely to die. This information is not addressed in this table. You want to address the second question, which is important also by Dr. Ali. He's saying this data is from your hospital where you have CCRT. Does that explain some of your findings?
I'm not sure about it, but according to ICU office say, in survival rate, there is you can see it is only length of stay. It was 0.1 day, less than 1 day. It is according to, I think, for CCRT activation or consultation from ICU. So I think, yeah, they have some response.
I think the other issue is the mortality is around 60%, which for in-hospital cardiac arrest, the mortality typically is higher. I expected actually for hematologic malignancy to have higher mortality than this. So this is great. We have a mortality that is actually, it is high, but it's not as high as, I don't know, the French study, what was the mortality? What was the mortality in the French study?
In the French study, it was I'm sorry. I think it was more than 60%.
Yeah, see, here survival rate is 14%. So mortality is 86%. No, this 6 months. Sorry, this 6 months. Found 24, 18% discharged alive from the hospital. So survival rate from the hospital is 18%. So mortality 82%. So in our study, it's less. It's around 60% mortality. So maybe one of the reasons that Dr. Ali mentioned could be the having CCRT. Addressing goals of care before coming to ICU is important also. And you're going to be looking at the rhythms in these cardiac arrests to see if these are code blue, just to make sure that they are true cardiac arrest, not syncope, for example, or something like this. Right?
Right, yes.
Okay, any other questions? There are other, we need help with unmuting, Rose. Dr. Farhan Anazi, can you unmute Dr. Farhan?
Okay, doctor, just wait.
السلام عليكم يعطيك العافية أبو سعيد دكتور عربي for really such a great presentation. Thank you Modi for nice presentation. ممكن just تعليق بسيط على question of دكتور علي. طبعا I think CCRT in the hospital does not cover cardiac arrest patient. I think those patients did not pass through the CCRT activation before the arrest. يعني ممكن تكون sudden cardiac arrest before activation. الشيء الثاني CCRT established في الحرس الوطني was I think 2010 وفي lots of data عندنا في الماضي data, maybe it's beyond that. I think before even 2000 CCRT activation. I'm not sure if this help in clarifying some issues.
Excellent point. Very good. Great job, Dr. Modi. I think this is fantastic. I think we need to, I think you are almost there. Additional work is needed. And after this, we like to see this in a full manuscript. So thank you. Great job.
Thank you, Dr. Thank you.
Dr. Abdurrahman, are you ready now? Abdurrahman Al-Mai. Can you share? I cannot hear you. Can you unmute?
You hear me now, yeah?
Yes. Can you share your slide?
Also, they not allow me to share its screen. Can you give me the option to share the screen? Okay.
You can now, doctor. You can now.
So what about you, bacon hair? Where are you from? I'm called bacon hair. Yeah,
Okay, now it's clear.
It's not full screen. It's a little slide.
Maybe.
Are you sharing the screen or the file?
I will share the file now again. Okay.
Yes, better now.
Yeah. Hello, everyone, and good night. This is Abdurrahman Al-Mai, ICU Fellowship, National Guard Hospital. I'm so happy to be for this opportunity to involve in a trial group, and it will add value for me. I think today we have a bunch of interesting to the presentation about discussed by my colleague, Dr. Modi and Dr. Samah and Dr. Hatem about some interesting topic. My talk today about timing of non-code patient, but first of all, I will just I appreciate the help team for their help, Dr. Yasin and Dr. Farhan and Dr. Sajid. Also the Dr. Fahmi and Dr. Hani and Dr. Musharraf, Widian and Filwa. My background for this presentation, cardiopulmonary resuscitation is one of the essential pillars used in the health service for the patient, but this is pillar maybe in period without worth. And the data for practice of non-code patient or DNR among critically ill patients in Saudi Arabia are limited. For that, we are try to object our study to by this study to compare outcome and length of stay of patient in ICU hospital with non-code status and full code patient. The other thing, the methodology of this study, study area and setting, the study was conducted in King Abdulaziz Medical City, Intensive Care Department, National Guard Health Affair of the Central Region between 1999 and 2017. And the study subject, it was about ethical consideration. IRB approval was obtained from the Institutional Review Board, and patient confidentiality was maintained. Including criteria, all ICU patient was included. Excluding criteria, we exclude the readmission within 48 hours and also the branded and parent patient. The study design was a retrospective chart review of collected data from the ICU database of non-code status and data extracted from the secure database in intensive care, which is maintained by data collector from 1999 2017, respectively. So this is the methodology, and we talk about the result of this study, and we found in the first table, which is more than of how patient were admitted as a cardiac disease. If you see my mouse, it will appear here. Most of the patients, 53.8 is the cardiac patient admission. They are labeled later on as non-code patient when they admitted to ICU. Almost of them, most of them, they are male. I remove female from here, but most of them, more than 57 patients, they are male. We also found the around 80% of non-code patients were mechanically ventilated. Around 82.6 they are mechanically ventilated of non-code status. The second table, as shown in this table, you can see no code was higher in the before 2011. It was around 2030 for full code, but they are now it was 31 for non-code and 2030 for full code. But there huge improvement in after 2020 to 2012, which is around 58 full code and 48% in non-code, but they I would explain these or interpret by improved health practice and a guideline of management to reach these outcome. This table, also the laboratory finding. The laboratory finding for this patient in 24 hours of ICU admission, you can see non-code status patient has worst result for all lab and GCS and lactic acid and INR and also BF ratio. So these mean all non-code status, when they admitted to ICU, they are more sick. The other schedule, which should talk about outcome of non-code versus full code, and as you see in the median duration of mechanical ventilation of non-code was 5 days compared to 1 day for full code. The non-code patient, they are have large ICU stay compared to the full code. When they see it's around 67, they still ICU length of stay. It's around 6 days, 6.3 for length of stay versus full code, which is 3.5. Also, as the median number of day to labeled patient here down as a non-code patient is 3 days since the patient admitted to ICU. So the median number of days to label them as non-code patients is around 3 days. The last schedule about the multivariate analysis shown for every 1 year increase in the age, this is increase around 20%, increase around 20% of to label patient as non-code status. Also, the patient were admitted or were admitted as surgical case. As surgical case here is around 83%. They are less likely to have a non-code status or labeled as non-code. This also this multivariant analysis shown that a patient admitted from 2000 or 26 to 2017 are less likely to labeled as non-code when we compare it to patient before 2005. This is the result of study, and we have concluded about overall, the median age of non-code patient was 67 years compared to 57 for full code patient. The ICU length of stay for non-code is 6.3, but the hospital length of stay around 16 days. The non-code patients who are older, they are high risk to labeled as non-code. We found the same median for the other non-code admission. The most disease among non-code patients is the cardiovascular disease. Thank you for listening. This is my presentation. If you have any question.
Great job, Dr. Rahman. Thank you very much for this excellent presentation. Can you go a few slides before? Just want to clarify one issue. Can you go back?
This or
No. Before. Yes, here. So just so before 2005, just these percent, just to be clear, 19% of the patients, of all patients, were eventually made no code. And doesn't mean made no code when they arrived to ICU. Some of them deteriorated before they died. They made no code. So 19%. Now, these percentages are percentage of the column, not percentage of the row. So it doesn't mean that 2005, 18% of the patients, and 2017, 58% of the patients were made no code. Just make sure. Not 58% were made no code. It's not true. It's 18% of this. 18% of the patients full code are in this time period. What you need to compare is this percentage to this percentage. For no code patients in 2005, full code 18% of the total in that period, while 29%. So more no code compared to full code. Here's the opposite. So no codes are actually lower in recent years. They were more in previous years. There are
yes,
fewer in recent years.
Yeah, that's mean, which is, I would explain by increase improve health practice. That's mean from 2012 to 2017, 58, as you said, 58, they are full code, they are not labeled as non-code, which is compared to other side. So these percent, as you said, it's mean for the row of these presentation is not the column.
Yeah, so multiple reasons. One, maybe the acuity is becoming less, so patients become less sick because Apache is coming down. Maybe the patients are no code at risk before ICU. So it's not only about the practice is improving, it's a complex issue. But basically the fewer no code in recent years. I think it's probably reflecting generally that the outcomes of ICU patients has improved. I think you could say this. Also, I think generally where we have more ICU beds, for access to patients is better. So we bring patient earlier, so they do better generally. I think the outcome is generally better. And you see this on the multivariate analysis. Recent years is associated with less no code.
Yes.
Can you, like less than half.
Yeah, the age, mean the age. So
this one is very important. So recent years, odds ratio 0.4 يعني تقريبا 40%. 40% بالمقارنة مع before 2005. So it's less than half.
It could be involved because as you said, the ICU beds and the.
Also, we have CCRT, so we're addressing code before coming to ICU. Multiple reasons, but there is a reduction in the number of no codes in the ICU.
Yes.
Okay, questions from the team? We have a question from anyone? Dr. Samah, I think you raise your hand. You have a question? Can you unmute? Anybody? Please unmute. Dr. Samah, you have a question? You're unmuted now.
Yes. Thank you, Dr. Abdurrahman, for this great presentation and a relevant subject. If I can ask you, why did you choose this topic, looking for the no-code patient?
So as we said in the first slide, there are the practice in Saudi Arabia about the non-code patient or DNR patient is very limited data. So we try to explore more and to know that more data about this entity.
Yes, and I think
Great.
that's good question, a good answer also. And there's lots of variation between hospitals, and I think this may be a good information for people to know how no-code is practiced in some of the hospitals. So maybe they can do the same. You know that there are some hospitals don't practice, or they practice very limited no-code. Dr. Farhan Al-Anizi, if you can please unmute Dr. Farhan.
Yes, I'm muted. يعطيك العافية عبد الرحمن for such a great presentation. Again, questions of Dr. Samah, it's very excellent questions, and I have maybe a suggestion or answer for that. طبعا we have to address the code status for patient who needs to be no code, because as you know that يعني demand على healthcare for the last few years is increasing, and there is many salvageable patients, they don't have beds, while the ICU beds are occupied by patients who should be no code صراحة. Second thing, we need to generalize the concept for the whole kingdom and make maybe one practice for everybody in the kingdom, and saving ICU beds for patients who need it. يعطيكم العافية. That's why it is excellent questions and excellent research questions.
يعطيك العافية.
Very good. And please, for the residents, Abdurrahman, or take notes of these comments, because this will help you in focusing your discussion when you write the paper, because these are relevant points.
Okay.
Very good. Excellent, Dr. Abdurrahman. Thank you very much. I think we'll move to the next presentation. And next presentation will be given by Dr. Samah Al-Qahtani. She's going to present on another important topic, which is Guillain-Barré patients admitted to the ICU. Dr. Samah. And also, I just, while Dr. Samah is loading her slide, I'd like to thank the coordinators who've done a remarkable job helping in this project. Dr. Musharraf Sadat, Dr. Ms. Wadian Al-Wahibi, and Felwa, who've really been patiently working with the team and continuously, and Dr. Hani Tamim for doing the analysis. It's been really great help. So thank you very much. Dr. Samah. Can you unmute Dr. Samah, please?
أيوه. السلام عليكم.
Salam. Can you share your slide?
Can you put me co-host so I can share the slides?
Rose? Okay, you are now.
You can see my slides?
Yes.
Thank you, Dr. Yassin, and I share you the thanks for the supporting team that we have, Dr. Musharraf, Dr. Wadian, and Filwa. They have we bother them a lot actually with a lot of questions, and we are thankful for their work with us. So I'm giving you today an update about my research, characteristic and outcome of Guillain-Barré syndrome patient admitted to the ICU. And today I'm gonna talk about, as you know, the 30% of Guillain-Barré syndrome patients required admission to the ICU and mechanical ventilation. The overall mortality rate was ranged from 8 to 20%, and the improvement of the mortality was observed during the 2000s after the improvement in the treatment modality presented to this type of patient. As was known by prospective and retrospective study, predictors of respiratory failure include valvular dysfunction, facial weakness, and at presentation, and the measurement of forced vital capacity and negative inspiratory force. My objective is to, in this presentation, to give you an update on the ongoing research of identifying the predictive respiratory failure and the requirement of mechanical ventilation, and to estimate the functional recovery at maximum follow-up. So it was a retrospective observational study of adult patients with GBS who required ICU admission and the ICU of King Abdulaziz Medical City, Riyadh. We include all adult patients admitted to the ICU with a primary diagnosis of GBS between 1999 and 2017, and we exclude all other neuromuscular disorder. The data collection, we use the ICU database, and we extract extra data collected from the medical record. We analyzed and compared the characteristic of mechanical ventilated and non-mechanical ventilated patient. We assessed the association between functional recovery and the seasonal variation. And we used the categorical data represented the frequency and percentage and compared using chi-square and Fisher test. And continuous data was presented as a median with first and third quartile. So our results showed that a total of 58 adult patients with GBS required ICU admission over 18 years in ICU of King Abdulaziz Medical City, Riyadh. And what I'm presenting today is data of 25 patients. We're able to extract their information from the medical record. I will mention the predictor respiratory failure, the ICU complication, and the functional recovery. So the clinical characteristic at ICU admission, we're able to find the valvular dysfunction and ability to clear airway and facial weakness in 8, 6, and 8 patients. This is with the presentation initially in ER. It was reported in 30% of mechanical ventilated patients, and 33% and 16 and 25 in non-mechanical ventilated patients. The p-value was significantly positive. The respiratory distress was observed initially in ER in 5 patients who eventually required mechanical ventilation, and in 2 patients who did not. Upper respiratory tract infection and preceding symptoms of GI infection, especially diarrhea, was observed in 9 patients. It was divided between the non-mechanical ventilated patient and mechanical ventilated patient. The maximum forced vital capacity was recorded in the medical record, Q4 and Q6 for some patients. We were able to extract the median and the maximum number for the vital capacity. It was a median of 1.8 milliliter per kg. It was much lower in the mechanical ventilated patient with a median 0.7, which was significantly p-value, and the maximum negative inspiratory force was with a median of minus 35. In the treatment modality, IVIG was most of the patient received IVIG in 21 patients, and the other modalities was received as an extra addition, except for 4 patients received plasmapheresis alone. There was a significant change in the effect on the mechanical ventilated patient and non-mechanical ventilated patient. We had 5 patients who received the steroids with, in addition to the IVIG, or in addition to the plasmapheresis. We saw it's the same in the mechanical ventilated and non-mechanical ventilated. The vasopressin was used more in mechanical ventilated patients. In the complication of ICU and hospital admission, DVT and BE, hospital-acquired pneumonia, mainly VAP, and infection with bacteremia was observed. Bed sores and acute kidney injury, and the need for renal replacement therapy was observed more in the mechanical ventilated patients. Functional recovery, we used the Hughes scale, which count for the functional recovery at maximum follow-up. We're able to conduct data for patients from 2020 until the last follow-up for them 2019, with the median scale of 3. And the mechanical ventilated patient, it was worst. For that mean it's worse scale. That means worse recovery. We'll mention that in details, the grading for the Hughes scale. So the Hughes score was used as the ranking for the functional recovery for the patient post GBS, and it's graded from 0 to 6. 6 mean death and 0 healthy. Grade 1, that means the minor symptoms or signs related to the GBS, but the patient will be able to assess himself in daily living. Grade 2 to 4, they will be needing more assistance and chair bound at grade 4. Grade 5, that means they need mechanical ventilation. When we study the association between the Hughes score and the seasonal variation of GBS, which was well-known phenomena, it was observed in adult and pediatric population in retrospective and prospective studies around the world. And we're able to observe more admission in the colder season, and with the higher Hughes score at maximum follow-up, as you can see in the graph. And the warmer season, they have lower need for mechanical ventilation and lower, better functional recovery at maximum follow-up. So my conclusion that mechanical ventilated patient had higher risk of developing complication. Valvular dysfunction and ability to clear airway and facial weakness at presentation was found significantly associated with respiratory failure and mechanical ventilation requirement. Seasonal variation did not associated with worse functional recovery at maximum follow-up. Thank you.
Thank you, Dr. Samah. Great presentation, very interesting findings, excellent and thorough evaluation. So Dr. Samah had the data extract from the database, but she went and reviewed the medical records. And so what's your plan now for the rest of the patients? What do you plan to do?
We were able to contact with the medical record to get more data, because we had some issue with the older files. It wasn't on the electronic medical records. So we're waiting for the medical record to help us out with the files, the paper files from the period from beyond 2002.
Excellent.
Mainly.
We have a question from Dr. Ali Junoubi.
Well done, Dr. Samah. Very nice presentation and topic. Just a small suggestion, if you could include the different variants of GBS, if it is available, and compare the outcome between them, it will be a great also add to the study.
Thank you for the suggestion. Yeah, we are trying to get that also from the medical record.
Thank you very much.
Excellent.
Shukran.
Any other questions? So I think some novel findings is the seasonal variation. It's interesting. So if you manage to get a larger sample size, this will maybe more prominent and more clear. But the rest of the information very interesting. That the patients who have complications or mechanical ventilation and complication are associated. It's not obviously, it's not because of mechanical ventilation develop complication. It's because they are more severe disease. They required mechanical ventilation and they were developed different complications. Excellent.
Yes, you're right.
Okay, very good. Thank you, Dr. Samah. This is really, I think that will be a really nice paper and there will be good addition to the literature.
Thank you, Dr. Shukran.
Take it off. Last presentation will be given by Dr. Hatem Arishi, who is going to present on a very interesting topic of the use of phenylephrine versus vasopressin as second-line therapy in septic shock. Dr. Hatem.
Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you, Dr. Yassin. Good evening, everyone. And it is my great pleasure and I'm thankful for this opportunity to present today my project, which is a retrospective cohort study that's talking about combination of phenylephrine or vasopressin as a second line and combination with phenylephrine in critically ill patient with septic shock.
Can you put full screen?
Yeah.
Full screen.
As a background, 50% of the contributing factors of in-hospital mortalities can be attributable to sepsis. And according to Surviving Sepsis Campaign, norepinephrine is recommended as the first-line vasopressor for septic shock. And also for refractory septic shock, the current Surviving Sepsis Campaign also advocates vasopressin as second-line vasopressor after norepinephrine in those patients. Although, and that's why, that's because there are some trials like VANISH and VAST trials which showed no mortality benefit of vasopressin per se, but there was decrease of catecholamine requirements. About phenylephrine. Phenylephrine is a pure alpha-1 agonist that is a very potent vasoconstrictor. And the current guidelines about the use of phenylephrine is still limited, except in certain conditions, like norepinephrine-associated arrhythmias, persistent low blood pressure in spite of high cardiac output as a salvage therapy, and the limited use of phenylephrine is due to the insufficient data, and more research is required to assess this impact. Actually, there is some literature about phenylephrine in septic shock, and there was two RCTs with a few number of patients compared phenylephrine with norepinephrine, but there was no significant difference in mortality between the two groups of phenylephrine and norepinephrine as first lines, but there was a network meta-analysis resulted in imprecise estimate, and it was a wide confidence interval when they compared the phenylephrine and other vasopressors. So our aim of the study was to compare the outcomes of phenylephrine and vasopressin when were they combined with norepinephrine as second-line pressors for hemodynamic support in critically ill patient with septic shock. And outcomes were ICU mortality, hospital mortality, ICU and hospital length of stay. For our study design, it was a retrospective chart review of all septic shock patients who received phenylephrine or vasopressin as second-line norepinephrine from 1999 to 2017. And our study area It was in the ICU of King Abdulaziz Medical City in Riyadh. And we included all septic shock patients who were 14 years or older, as defined in sepsis 3 definition, and patients who received norepinephrine and who were combined with phenylephrine or vasopressin. And we excluded all patients who received other vasopressors or a combination of all the 3. Or any patient who were admitted to ICU, readmitted to ICU in the same hospitalization, no code patient, brain death patient at admission, and burn patient. So for our analysis plan, the data were extracted from ICU database, which was maintained by a data collector. And all septic shock patients who received norepinephrine were divided into 2 groups, which is phenylephrine group and vasopressin group. And we compared those 2 groups in baseline characteristics, admission hemodynamics, chronic diseases, and outcomes. And we did also a multivariate logistic regression analysis for some variables that I will mention in the results. Over an 18 years among septic shock population, there was 158 patients who received phenylephrine and 129 patients who received vasopressin as vasopressors in combination with norepinephrine. And when we compare the 2 groups in the patient characteristics, both patients had median, the group 1 has a median age of 60.9 years, and the group 2, which is vasopressin group, had 67 years as a median age. And interestingly, it was the distribution of gender, it was almost the same in the both group. For male gender, it was almost 38%. Of the sample, it was they were females. And because there was no patient in our database that received vasopressin before 2011, we divided them into 2 groups concerning the time period for the multivariate regression. And all 129 patients of vasopressin were counted from 2011 and beyond, and 158 patients of the phenylephrine group were distributed before 2011 and beyond. And this was done because for the concern of multivariate regression. For the Apache score, there was no significant difference between the 2, but there was an increase of 3 points in the group of phenylephrine, which is group 1. So for the lactic acid, it was higher in vasopressin group, which was a 5.9 versus 4.2 in phenylephrine group, although there was no significant difference. And for the other thing in this table, when we compare the hemodynamics, actually the urine output as baseline, it was higher in the phenylephrine group. And the baseline, it was higher in group 1, the phenylephrine group, with 845 ml in the first 48 hours, 24 hours of admission, versus 550 ml in the first 24 hours of admission, which was a significant difference between the 2 groups. And the heart rate, it was actually even higher and more interesting than the urine output in the phenylephrine group, which was 141 beats per minute in phenylephrine group and 123 in vasopressin group. For the median MAB, it is low in both groups, but the vasopressin group, it was higher than the phenylephrine group. Regarding the chronic diseases, the 2 groups has no significant difference in distribution in liver renal, immunocompromised, and cardiovascular chronic diseases per se, except in chronic respiratory diseases, which was higher in group 1, with almost 29% of the patient in group 1 had chronic respiratory diseases, and only 13.2% of patients in group 2 receiving vasopressin had chronic respiratory diseases. Regarding the ICU mortality, regarding the outcomes, there was no difference in ICU or hospital mortality between the two groups, nor the ICU and hospital length of stay, with an ICU mortality of almost 45% between the two, with the two groups, and ICU length of stay, it was 6.9 in the phenylephrine group and 4.9, which is almost 5 days, in the vasopressin group. And for the requirement of renal replacement therapy, it was there was no significant difference between the two groups. Although the urine output, it was higher, it was significantly different between the two groups, which was the phenylephrine had a higher urine output at the first 24 hours of admission. For the mechanical ventilation duration, it was actually significantly different because phenylephrine had a median of 6 days versus the vasopressin group has 4 days of median days and mechanical ventilation days. When the variables were adjusted to Apache, the time period, the heart rate, mechanical ventilation duration, and chronic respiratory diseases, to compare the two groups for the hospital mortality, the group 2 had higher risk of in-hospital mortality with an odds ratio of 2.08. In conclusion, over an 18 years period, among septic shock patients who received norepinephrine, 158 only received phenylephrine and 129 only received vasopressin as second-line agents. There was no difference in ICU mortality, hospital mortality, nor ICU and hospital length of stay, and the vasopressin group showed higher risk of mortality when adjusted to Apache score, Apache 2 score, time period, heart rate, ventilation duration, and chronic respiratory diseases. And the ventilation duration is shorter in vasopressin group with median days of 4 versus 6 days in phenylephrine group. And thank you so much.
Excellent presentation, Dr. Hatem. Very interesting, very exciting. It's going to be, I think it's going to be an important addition to the literature. So thank you very much. Clearly, a very sick group of patients. Apache of 30 is very, very, very high. So these patients who are septic shock requiring a second vasopressor, especially the ones we select for phenylephrine and vasopressin, the one with typically more tachycardia, look like very, very sick.
Yeah, actually there was one study, one RCT, it was done on in 2010. It showed that the patient who received phenylephrine, it had significantly lower patient than norepinephrine. But here it is higher.
Lower heart rate?
Yeah, heart rate.
Lower heart. Yeah, but these are baseline. These are baseline heart rates.
Yeah.
Yeah. These are baseline. This is the first 24 hours. So this is the worst value in the first 24 hours.
Mm.
So great job. Any questions from the attendants? I think the multivariate analysis probably needs some additional work, but it's showing it's showing actually vasopressin is worse, but I'm not sure this is yani, we need to add the lactic acid because there's some imbalance in the lactate as well. But it doesn't show that I mean, it shows that phenylephrine is not worse. At least it's not worse. It's probably similar to vasopressin. You know, there's a lot of debate about phenylephrine. There are people who don't like it, but there are some hospitals who use it extensively.
As the first line also?
Not first line, but commonly.
I think Dr. Al Janoubi is raising his hand. So,
Dr. Ali?
Thank you very much, Dr. Hatem and Prof. Yassin, and sorry for making a lot of comments because very interesting topics addressed today. First of all, just maybe a typo that sometimes is written like phenylephrine or vasopressin, and sometimes it's written phenylephrine.
Yeah, that I just noticed right now. I'm sorry.
I believe phenylephrine or vasopressin, Nur Abi. And as correctly mentioned by Prof. Yassin, that the baseline heart rate may be encourage the physician to choose phenylephrine in favor of vasopressin. And my last question, why would we adjust for Apache? We know that Apache is an indicator for severity, so why would we adjust for it? Like, for here, the Apache is more in phenylephrine group.
Yes.
But if we adjust for it, the mortality will be higher in the vasopressin group. So does this make sense? I don't know.
Well, the point is that the two groups are, this is not a randomized controlled trial, obviously, صح? This is an observational study. So in one group, the Apache is slightly higher than the other. So if you don't adjust, the mortality will be higher in that group because of severity. So you have to adjust for severity. You have to adjust for it.
Okay. Thank
So
you
you have to
very much.
adjust for the imbalances. Try to address all the imbalances. But the other one that is looking different, if you go back, Hatem, is the lactate to me.
Yeah.
And I think, although it's not significant, but it is, I don't think we can ignore it. 4.2 versus 5.9. P-value 0.1 for multivariate should be included. So this is not a small difference in lactate.
Yeah, I think it should be included in the adjustment. So we have to see about if there's a real difference in mortality in this study. Dr. Ahmed Nahas is raising his hand.
Dr. Ahmed.
Yeah, Ahmed Nahas.
Can we unmute him, please?
السلام عليكم.
وعليكم السلام ورحمة الله.
مساء الخير جميعا. Thank you, Prof. Arabi, for organizing this and allowing residents and fellows to participate. And also, I would like to thank all the speakers. And Hatem, since you are my friend, أبغى أمسي عليك تمسية خاصة. I would love to borrow the question of Dr. Samah. Since the literature tells us when to use phenylephrine, what triggered you to do this very extensive research over a long period of 18 period?
Over 18 years period. Okay, I will tell you first why I chose this topic. This topic, actually, phenylephrine is not recommended because there are no much study on it. And people don't like it because it's bad physiology, and there is a theoretical risk of hepatosplanchic hyperfusion that can be caused by phenylephrine. Although it's not clinically significant, and I think there was one study did this, and it also found there is no impact on hepatosplanchic hyperfusion. And the other thing, I chose the 18 years period because actually it's a trigger to have an 18 years period of data. That's one. The second thing that we don't find much, actually, we don't find much phenylephrine used as second line vasopressor. And it's not that easy to find a considerable sample size within few years. So I'm very lucky for that. If there is a chance for us with an 18 years data to give us a hint about something like should we use phenylephrine or not, we should look for it. Since there is no much data, we have to look for data. So that's why I chose this topic. For their recommendation about how to use phenylephrine, actually this recommendation is just in case you are stuck and you are stuck with other vasopressors, and because we don't have much data on phenylephrine, you can use phenylephrine since it's not that much studied. And I think that's it.
Hatem, I think this is a great question actually by Dr. Can you mute the microphone? Great question by Dr. Ahmed and Philippe and Dr. Ali. And this question about why you choose your topic actually will be in the introduction of the paper. You have to justify why your research is needed. What's your research is going to add to the literature. So here, I think you made good points, but this should be supported by references from the literature.
Yeah,
the studies
exactly.
are limited.
Yeah.
There is actually systematic review about different vasopressors, which found very little about phenylephrine.
Exactly.
And also, I think you need to probably find some studies about the variation in practice. Always a good thing to show that there is variation. There are some centers use a lot of phenylephrine, some don't use it, etc. Because this reflects that we are not sure if it's good or not good. So this, I think these arguments are good to make a case for your study.
Yeah.
Dr.
Muhammad
الشهراني.
نعم. مساء الخير جميعا. Thank you حاتم. Thank you Dr. Arabi. I have a comment and a small question. The comment is I would like to thank Dr. Arabi for this initiative and supporting this kind of research environment among the residents and trainees and supervising them. Hopefully we'll get, year after year to get more support and we see more products. My question, Hatem, great question, and I think I agree with my colleagues before. But as you know, as this is a small observational retrospective study, it's always hard to comment on mortality. There are a lot of confounders that we need to adjust for. I'm not sure if I missed something, but what is the type of shock here? Are you talking about all hypotensive patients or the septic shock?
All septic shock patients also, only septic shock patients.
Okay, the septic shock. Okay, because you know there are like cardiogenic shock, and some of those agents are not.
Yeah, actually, that's one of my because when we distributed the data, what we have in the chronic disease section, the chronic cardiovascular disease was almost the same for both group, with almost 90% in the phenylephrine group and 28% in the vasopressin group, and that was a little bit. It's good to compare both groups since there is the theoretical risk of about the effect of phenylephrine on those patients.
Yeah, also for adjustment, I agree with Dr. Arabi. There are other confounders that sometimes it's numerically significant, but when it comes to the p-value, it's borderline. So don't forget to adjust for example, immunosuppressive patients. There is a big difference numerically, but I'm not sure. I didn't see the p-value here. for example. I mean, and maybe if you think this is could have an effect on the outcome for those patients, this is one of those you need to adjust for in the multivariate, especially that you have like 300, 400 sample size. So still you have room for adjustments for some variables. Other than this, great work and good luck.
Thank you so much. Thank you so much, Dr. Mohammed.
Thank you, Dr. Muhammad. Great,
Great
recommendations. Yeah, great points.
Yeah.
Any other suggestions or comments? I think this is a really interesting session today. Great presentation, Dr. Hatem. I think this will translate to a nice paper that will be helpful actually for people to understand this topic more. We need to do the additional adjustments, etc. But I think we're in the right direction on this one. So great work. So great work for all the presenters, for you, Hatem, Samah, Abdurrahman, and Modi. Great job. And for all the other residents and fellows who are at different stages, we have, I think we have finalized 4 or 5 already, so they were presented before. And so we are moving in this direction. In the Saudi Critical Care Conference, several of the residents will be presenting. So also we'll hear more progress about their projects, and we're very excited and happy about this.
And I'm really thankful for Dr. Musharraf and Dr. Hani Tamim for giving the time for the analysis of this data, and also Ms. Diana and Philwa for arranging for that, because they took some time actually. I'm really thankful, and it needs more time, obviously. Yes. Yeah. Thank you so much.
And thank you everybody for attending, and have a good night.
Thank you.
Yeah, assalamu alaikum.